Hello and welcome to WNHH Radio's Dateline New Haven. I'm your host, Paul Bass, inviting you to look behind the headlines on the stories that make the Elm City tick. Greg Gonzalez and Yusuf Ransom of the Yale School of Public Health help keep New Haven ticking and alive. They're dedicated to combating AIDS and HIV, and as we approach World AIDS Day, they're here in the WNHH studio to update us on the shape of that challenge in 2018. Thanks for coming in, folks. I appreciate you both made the time.
You're welcome.
Nice to have you in the studio, and thanks to Yale New Haven Hospital for providing support for today's program. So Saturday, December 1st is World AIDS Day. And why are we marking it and how? Greg?
So, though it may be out of the headlines compared to when the AIDS epidemic first struck the United States in the 1980s, we still have over 1 million people in the United States living with HIV, 15% of them who generally don't know their status. And we have a exploding epidemic in the American South and among communities of color, particularly young men who have sex with men of African descent.
In the South, or in general?
Well, in general.
So it's exploding. It's getting more.
We have young men are increasingly who have sex with men are increasing numbers.
Why does that happen, Greg? We've made so many, or Yusuf, we made so many advances, and we'll talk about that in this hour. I mean, I'm just thinking consciousness-wise as someone who's not an expert like you guys, I'm thinking how it was a panic at the time. People were dying, have gotten better medication. Doesn't seem to have as much stigma, at least where we live. What happened? Why is this back?
Well, I think in general, the epidemic is still here in one way, in part due to the access. So much of the challenges that we experienced early on in the epidemic in terms of access to preventative care, access to treatment, unfortunately is still around today. And so, we can, cite some statistics thinking about, the proportion of African Americans, for instance, who are eligible for current technologies like pre-exposure prophylaxis, right, in comparison to the actual proportion that actually receives or are currently using PrEP is still disproportionately high, right? So I think although we've made significant advancements in terms of treatment and opportunities, unfortunately, the structural barriers such as access to those opportunities still exist and are disproportionately affecting, minority populations and particularly individuals in the South where, as mentioned, there are sort of structural issues around access to care. And those are some of the reasons why, unfortunately, we're still seeing sort of higher rates of HIV, particularly in those areas among those communities.
It's interesting when I hear you talk about that because, when Greg and others were starting with ACT UP and just trying to get people to care about this and to recognize that it was happening. I remember a U.S. Senator like Jesse Helms would say, well, this is good. This is God's way of getting back at gay people for what they deserve for their immoral behavior. And have we come at least far on that question? Is that prejudice still there? Because you mentioned men having sex with men in the South. So race is caught up and barriers to health care for members of minority groups pretty much cuts across, right? We could be talking about diabetes. We could talk about all sorts of diseases. But is there something specific still about a stigma carried with AIDS and HIV in parts of our country? Are people still embarrassed to say they have it? Is still seen as like, is it still a homophobic opportunity when it's discussed?
So I think there are two things. One, regarding the point you made about the comment that HIV is a sort of like a punishment, right? So we've have a lot of robust data right now to show that, for instance, it's not necessarily HIV specific behaviors like more sexual partners or higher proportion of unprotected sex or
sharing
drug
needles.
use or sharing needles, right? So there's evidence now showing that African Americans particularly aren't more likely than, let's say, white or other racial ethnic groups to engage in those behaviors, right? So that's sort of like a myth that we dispel through research that is not necessarily sort of the sexualized identities or the specific engagement in risk behaviors, but in fact due to the circumstances. So there's work that had been shown that the social and sexual networks are typically smaller among African Americans. So the per likelihood of acquiring HIV within those groups are higher. So it's, in other words, it's not behavior. It's not sort of an inherent innate characteristic, but it's more of the environment. So I think now that we've,
Can you just explain that for a second for me? Because I've been trying to catch up with that idea there. So when you're saying it's a smaller social network, does that mean that disease gets passed along and festers more when people have contact with a smaller inbred group?
So not necessarily. So I think when we say social network, so we think of, for example, interracial dating or or couples, right? So it's well known that African Americans are more likely, for instance, to date within their race, right? And in some places where there's
I didn't know that. Yeah.
yeah, and in some places, particularly in the South, where there's historical segregation, for instance, where African Americans are relegated to certain communities, you find that if, for instance, there's a higher population of individuals who might be exposed to HIV, but within the specific area, we find that risk is just naturally increased because there's a higher prevalence pool or proportion of people, let's say, if you will, that's affected. So again, it's not necessarily the behaviors per se, but it's just that, again, think of the historical context of segregation and other issues where if you have a community that's not getting, for instance, the right access to medications,
All right. So
right?
again, it still starts with access.
Right. So you think
So
of the structural factors.
so if there's no more behavior that leads to it, but if fewer the people who contract the disease don't get help for it, and they have a more insular group, it's going to spread in that group more.
That's correct. So again, just thinking more about the structural factors, the upstream factors, moving away from the sort of behavioral. Not that behavior isn't important; it still is. But again, sort of thinking about the wider community factors, the structural factors that can give an individual opportunity to get the appropriate care. This was well known, for instance, through new research that once individuals sort of reach undetectable viral loads, that HIV is no longer able to transmit, right? So you're thinking about how do we get entire populations now to undetectable viral loads, which at that point would lower the risk of acquiring HIV, even for sexual acts. So I think, again, it's sort of moving away from the individual behavioral characteristics, so thinking about the population level. How can we get the population virally suppressed? And those are some of the things around access to care and medication.
And can we just quickly, just for definitions, when we talk about AIDS, talk about HIV. HIV is you can contract first, and that can lead to AIDS. Just explain for the inexpert.
HIV, the human
Virus.
immunodeficiency virus, is the cause of
Right.
HIV
Like
disease.
yeah.
And AIDS is the final sort of clinical stage of the disease when you lose the ability to suppress opportunistic infections and cancers that you usually can fight off with a healthy immune system. So AIDS is the sort of final terminal stage.
Is AIDS still a death sentence?
As Yusuf is saying,
Or
it
HIV?
depends if you have access to care.
And that's why saying it's more prevalent in black
And-
communities in the South.
And if you look at the disparities in death rates to HIV, it follows the same trajectory as disparities in care generally in health across the country.
So most people, let's say you're white and you're not poor. If you get HIV, what's going to happen in your life from there on?
Well, let's talk about insurance and Medicaid. If you're in a state that expanded Medicaid, you're probably, whether you're poor or not, you're going to be able to get access to antiretroviral therapy and the treatment you need to keep yourself healthy and keep yourself from transmitting disease onto others. It's no coincidence that the American South has the vast proportion of the states that didn't expand Medicaid, which put people at risk for all sorts of diseases, including HIV, that would other be treated with regular healthcare provision.
And so if you do get the care, do get the medication, what is your life like leading from then on?
Well, there's robust evidence now that's showing that life expectancy among individuals with HIV, it's also approaching or very similar to life expectancy as someone who is not infected, so somewhere around 76 to 80 years. And we've come a significant way in terms of the medication. So early on in epidemic, one would typically take several, like 4 to 5 different medications. Now we're down to one single pill that someone can take, and also the side effects of those medications are less compared to when the medications were first originated. So I think, again, we've made significant strides, as mentioned, coming from 5 pills or so to 1 pill a day. And then, again, sort of fewer side effects. So individuals are, in fact, able to live healthy lives and suppress the virus within their body. So we've made significant strides in terms of the technologies available to improve health.
So is it fair that what I'm hearing is that, of course, while there's always work to do on the medical scientific front, there's always work to do on public attitudes. We've come far on the science. We have a big challenge still with access to care.
I think that'd be fair to say. I've been HIV positive since 1996 at least, and I've been on pills that have kept me healthy, and hopefully I'll live to a ripe old age, as Yusuf is saying, of
I hope
80,
so
80 or
too.
plus. But we see outbreaks of HIV among substance users and people who use drugs in places like Indiana, Lowell, Lawrence, Massachusetts, Cincinnati, Ohio. Although we know how to prevent HIV with clean syringes, manage opioid use disorder with methadone and buprenorphine to prevent people from injecting opioids in the first place, but we don't put them into use. So it's not just access to antiretrovirals in healthcare; it's active to preventive technologies such as clean syringes, methadone and buprenorphine, and other ways to prevent the transmission of disease through needle sharing or sexual.
And in New Haven, we were a pioneer in needle sharing. We were a Yale School of Public Health, Robert Heimer, or School of Medicine, and he did the original study in the trial here in New Haven that gave the basis for New York City to adopt distributing clean needles for other cities around the country. And now we've disbanded that program in New Haven over the last year, and we've turned it over to the Yale School of Medicine, correct?
So the needle exchange now is being run out of the community health van and
Is that run by the School of Medicine?
School of Medicine, Dr. Rick Altice and his team.
And how's that going? Is there still the same level of distribution, same contact with the community?
What is pretty clear is that harm reduction technologies and interventions across the U.S., including in New Haven, are inadequate to meet the need. So the access to clean syringes in the state of Connecticut, access to methadone and buprenorphine in the state of Connecticut, are still nowhere near what it.
I didn't know that about the clean needles. So in New Haven, it's still hard to get the clean needles.
Well, so the needle exchange van is the community health van is doing its job to try to serve communities who need access to clean needles. One community health van does not mean we have a comprehensive harm reduction program in the city of New Haven. If you start talking about New London, New Britain, Danbury, Waterbury, Hartford, I mean, we need to cover the entire state with harm reduction.
Are you saying those places don't? It's only New Haven that has one?
Hartford has, and there's smaller programs in other places, but we're a fairly wealthy state comparatively, but we don't have nearly what we need to deal with the.
And we're the healthy state that is broke in the government level. Do you see a challenge coming up with this election? How are you looking at the landscape in Connecticut in the year moving forward with the change in leadership in Hartford?
Well, you pay now or you pay later, right? You can invest in public health, which Yusuf and I spend our lives sort of studying and advocating for, or you pay later in terms of outsized healthcare costs for HIV infections and other infections like hepatitis C.
And prevention always costs less than the disease that comes. And we're talking about AIDS, HIV and AIDS, with two people who are on the front lines of trying to combat it and raise public awareness and do the critical research to finding solutions. Greg Gonzalez and Yusuf Ransom of the Yale School of Public Health. I'd like to talk a little bit about your personal backgrounds. So, Greg, you said you've been active with the issue since 1980s with ACT UP, the activist group in New York City. You're now a professor of epidemiology at Yale School of Public Health. Along the way, you've worked with some really interesting groups, including in South Africa and in Scott County, Indiana, doing this work. Did you get involved did it begin for you when you came down with the virus, or what was?
No, I came of age in the 80s. And anybody who
that's right. You said you got it in 96, so it was after you already were active.
Yeah, no. So if you were a gay man in the 1980s, the HIV epidemic was an overwhelming presence in your life and the life of your friends. And when your friends and your loved ones get sick, you don't sit on your hands, and you figure out how to help, how to save them. And that's why I ended up working with ACT UP.
Were you already in the medical field at the time? What were you doing?
No, I was a college dropout, waiting tables.
Really? Where was it? In New York?
I was waiting tables in Boston.
In Boston?
Yeah.
What kind of restaurant was it?
I can't. Well, several. There were different ones around Harvard Square in Cambridge.
How'd you where had you been going to Harvard? You dropped out?
No, I was at Tufts for a couple of years studying Russian literature and then dropped out.
Wow. And so did this work kind of give a purpose to your life from the beginning, working with ACT UP?
I didn't think of it in that way. It was sort of self-preservation for my community. So it was just sort of, if your house is on fire, you try to put out the fire.
And so what have you seen over the years as how public perception has evolved? We talked about it a little bit and how the work has evolved. So you were on the outside before. Is it fair to say you're on the inside now? You kind of got this institutional support to do work to get help directly to people? I mean, the old days, wouldn't you have been protesting the federal government to put money into the work you're doing now?
I still protest the federal government.
That's true. That's a good point.
No, I was arrested last summer in the Senate chambers in D.C.
Really?
In Washington, D.C. during the attempts to repeal the Affordable Care Act. So just because you work at a university doesn't mean you're on the inside.
That's right. That's right. So I didn't realize. How did you go to jail for that? Or?
No, I had a community service with our wonderful organization here in New Haven called City Seed.
Yeah, well, City Seed is a great group. Did you work at a farmer's market? Or?
I was doing a lot of sort of paperwork and grant writing and stuffing envelopes.
Mm-hmm. And so what was it when you made that decision to get arrested? I assume it wasn't the first time when you went to D.C.?
It was the first time I actually got arrested. I've tried in the past, but it was the first time.
Well, congratulations on succeeding. You know, it's never too late to succeed in new ways. But what made you decide to do that?
As Yusuf has said, access to care and access to preventive care is the defining factor of our time in terms of whether you're going to get sick and die from HIV or a whole number of diseases. And the repeal of the Affordable Care Act was a direct threat to people who are living with HIV, but anybody with a chronic disease, whether it's diabetes or cardiovascular disease. And so many people at Yale felt like it was something they had to do and had to try to stop.
Do you think we're out of the woods or not? Do you think with the new Supreme Court majority, ACA is endangered? If they find the right lawsuit, do you think John Roberts is going to try to keep it?
Now we're going into areas of expertise.
That's right. That's right. You don't have your degree in that.
No, I don't have to have a degree, but we're not in a favorable political climate for public health and healthcare.
That's a fair way to say it. Now, you were waiting tables. You got involved in ACT UP. How did you get back on the academic track?
I was in South Africa in 2006, 2008, and I wanted to finish my BA, and Yale had a program called the Eli Whitney Students Program for non-traditional undergrads. Ended up coming back to Yale, getting an undergraduate degree.
What was it like being undergraduate with people of a younger generation who have are still trying to grow up, kind of? You've been around the world and matured.
It was an experience. It's interesting to be taking biology and chemistry with 20-somethings who.
Were you yet at the age when their brains work so much faster that it kind of bums you out, or are you still young enough that you keep up?
I sort of kept up.
The thought of doing that now, which just depressed me.
No, it was fun. It was a luxury and a privilege to be able to get an undergraduate degree in my 40s. So.
And then you went on to
get my PhD at the Yale School of Public Health.
Okay, and you've become a lifer in New Haven.
Yes, I love New Haven.
Yeah, I do too. I really do. Greg, day to day, I was reading up on what they sent us over that you work on using quantitative methods to target and deploy services. So they say that the average in the U.S., 14% of people, you said this 15, don't know they're HIV positive, and they're higher in some states than others. So how do you use the work you're doing to lower that number?
So a lot of my work is model based, and so 15% of people don't know what their status is. That they're HIV positive, they don't get the care they need. They can inadvertently transmit the virus onto others. Trying to find needles in a haystack is a practical problem, but it also can be put into mathematical terms. And there are many different kinds of methods that have been used across different kinds of disciplines, whether it's looking for downed airplanes or searching for oil exploration to find needles in a haystack. And used a set of methods that have been used in other fields called bandit algorithms, which is a technical term. Did you ever play Battleship when you were growing up?
Mm-hmm.
It's like You Sunk My Battleship. It's basically using sort of search techniques that are based on kind of statistics. That
you're looking at where it's most likely. Like earlier, Yusuf was talking about, let's say, males having sex with other males in the South, and if they're of color, that kind of narrows your search somewhat.
But we're talking about like at the city level. Do you look in Dixwell or East Haven or Fairhaven or East Rock? Where do you put your resources, and trying to make those decisions in a more sort of.
And you've done this in New Haven, this map?
No, we've done it in computer simulation, and now we're talking to colleagues around the country about trying to do it in sort of putting it out into the field to test it.
That's only one of the areas you work on, correct? Because you also look in delivery, and you've talked a lot about that, about how to get people tested, how to link them with care, and again, you're using data to try to identify those bottlenecks. Can you give me an example of how you use data to figure out how to get people tested in the care they needed?
So the Centers for Disease Control tracks people's lab tests for HIV, and so we can tell who has been in care, who's been diagnosed, who's been linked to care, seen a healthcare provider, who's been in care for several years, who's gotten access to the drugs they need to keep themselves healthy, how many people have been virally suppressed or been successfully controlled HIV on their therapy. And by taking the numbers from the CDC, we can sort of track the population level dynamics across time of how many people get diagnosed, how many people fall out of care, how long does it take them to transition from being linked to care to get onto antiviral therapy, how many people drop out at different points during the process. So it's, if you think of your experience with healthcare as sort of a pipeline from your initial diagnosis to your successful therapy, there are bottlenecks along the way, and what we've done with our models is to think about where the biggest obstacles are, where the biggest barriers are, and it's often at the beginning of the pipeline, getting people diagnosed and into care, and then moving them from getting access to the pills to actually being virally suppressed.
When you go to bed at night, you go home at night, are you ever able to tell yourself, I'm positive I saved somebody's life by doing this? Or is that simplistic? Is it a greater communal search for solutions to epidemics and that I did my part to get us closer?
I mean, Yusuf and I work on the population level, so, we're not treating physicians and nurses and nurse practitioners who...
But if your work got somebody care who otherwise didn't get care, they would be staying alive, right? And then they might not have otherwise.
I'm hoping that our work sort of...
This is a question I often ask medical researchers who do such important work. How do you psychologically keep yourself going and picture the human impact you have when you're working in a theoretical and data-driven realm?
Well, we live in the city of New Haven, and we live in the city of in the state of Connecticut, which is deeply unequal. And it's not just the income disparities that are so stark within the state, but health disparities which are stark within the state. Now, if I go to bed at night and can sleep soundly, it's because the work we do at the Yale School of Public Health, not just in HIV, but across the board, is trying to address these structural and population level dynamics that make healthcare outcomes unequal, not just in New Haven, but in Connecticut and the United States and around the world.
And finally, I just want to ask you the obvious question about getting the MacArthur. You won a MacArthur Prize award this year.
Yes.
So you're a genius.
Not really.
You're saying you're not, but the people who decided who's a genius decide you're a genius. What's the significance of you getting that award? How does this help the work, and what does it say about society's recognition of HIV and AIDS?
I don't. First of all, they look at 2,000 people. I'm sure all of them were worthy of it, and it's sort of a little bit of a crapshoot.
It's like getting into Yale.
Yeah, it's like a lottery, but I do think it was a testament for this foundation's support for work on HIV, global health, social justice, and human rights, and the interface between all of those things.
Because they're saying it matters.
They're saying it matters.
Did they say it mattered 20 years ago? I'm not familiar with MacArthur's.
Yes and no. They have a history of supporting social activists and scientists. Not often people are working at the interface of both.
Mm-hmm. And you do that, and so does Yusuf Ransom and Greg Gonzalez. They're from the Yale School of Public Health. They work on HIV and AIDS, and they're here on Dateline New Haven on WNHH, your home for community radio, 103.5 FM, live streamed at newhavenmin.org. Yusuf, you told me before you went on the air that you grew up in Trinidad and Tobago and then in New York City, and you came to New Haven by way of Harvard Public Health School. How did you get involved in working on this issue, and when?
Wow, so this started actually roughly around 15 to 20 years ago, and so through experiences, seeing actually family be diagnosed with HIV and sort of
like immediate family, siblings.
Yeah, immediate family, cousins, and actually at the late stages within HIV diagnosis where they weren't able to get the required medication, for instance, in time to be able to live a productive life. And when I witnessed that, I realized sort of what are the other circumstances around that specific event, right? So thinking about the access within.
So this was a cousin who didn't get the drugs.
Right. Early, between, like I mentioned, about 15 to 20 years or so ago. And so, looking at that experience, right, and then seeing what sort of the environmental characteristics around that, and then actually when I moved to New York City, and I started going to undergrad at Brooklyn College. I worked.
So this was
At,
before college that you
right.
saw
Yeah.
this.
So this was
How
before
old were you?
college. So I probably around like 16 or between
And were you
just
already
a little
involved in
earlier.
science? Were you already on a STEM track?
No, so not even just
We didn't call it
it
STEM
was
back then, but
yeah, no, not even this had nothing to do with science, still sort of at
this is
the
when it
age
got on your
before.
radar, and this is when you cared. You said this matters.
Yeah, just sort of seeing that experience, and then when it really sort of came to life is when I moved to New York City and went to undergrad and had a chance to work at the health programs office at Brooklyn College, and actually for a World AIDS Day was asked to develop a presentation for to sort of characterize the epidemic of HIV among Caribbean immigrants in New York City. And so when tasked with that project, I started doing the research, looking at the data, looking at the distribution, the epidemiology, and realizing that it was also a problem. HIV was also a problem among immigrants of Caribbean descent that living in New York City. And so I started to look at the parallels. What were some of the structural factors that were happening in the Caribbean among individuals there, and then also realizing that they were facing similar structural barriers as immigrants that lived in New York City. And so during that time, I started realizing that, oh, this is not just a random situation. This is not just one family member. These are other people with similar experiences that are and populations that are being affected by similar sort of inequities and resources. And so then it started becoming sort of a formal inquiry research, right? Like, well, how do we look into factors
And
that
did this develop when you went to Harvard School of Public Health?
well, even before that, so actually, while working at the health programs office, sort of my original entry into public health was more focused on the health management side, the health policy. And through the experience working at the health programs office, I realized there was also a need to sort of work within the community, understand how do we promote health. And then that took me to the University of Michigan, where I majored in health behavior and health education. So at that level, that's when I started developing the research tools to be able to systematically analyze the problem, systematically look into what are the distributions and the factors that affect HIV risk, and that sort of translated into more work when I went into Columbia University. I did my dissertation and some other research around HIV and sexual behavior in general among West Indian migrants in New York City, and which sort of formalized through my training at Harvard and then here into Yale. So really it began, like I said, my experience through undergrad and working at the health programs at Brooklyn College to kind of get a full understanding of how the distribution of disease shapes in the population.
What was your cousin's name?
Sean, actually. Sean.
Shaun?
Sean.
And is he still around, or?
No, he unfortunately passed away. So this is one of the situations to where you actually kind of see, and you asked Greg, like, what are some of the things that motivate your work, right? So again, it's sort of the quest that knowing this is not just one family member, but you see the similar experiences.
And I understand.
People
You said you saw that it was
yeah.
it was a more general problem, barriers to care. Do you think of Sean every day when you do this work?
Absolutely. I mean, when you think of, well, what are some of the ways that we could have done things differently? For instance, right? Would he have been still wrong had we had sort of the right, access to medication, had the right sort of social support around the community? So I think definitely it's an opportunity to kind of do work that. In remembrance of Sean and in general, a lot of people who were families or friends or people that are also experienced losses.
Was that in the 1990s with Sean?
Yeah, so it's again about 15 and 20 or so years ago. And again, unfortunately, we still see the same things today. I think like in his early 20s. So actually, not even again, not sort of fully experiencing life. And the goal again today is to sort of have individuals live a full and productive life. And it is possible, again, given the type of medications that we have today. There's no reason why individuals should be, not experiencing the full.
You talked about this earlier in the program, Yusuf. What are you seeing as some of the major barriers, psychological, social, economic, that are making it harder for African Americans, Latinos, to get the same access to care, given that they don't engage in more behavior that puts them at risk for contracting HIV and AIDS?
Right. So this is a great question. I think there's an opportunity here now to talk about social determinants in general, right? So we think of the factors that, education, the basic access to employment, the basic access to affordable housing, right? So we think of these factors as integral to.
So if you can't afford rent, you can't afford health insurance.
Well,
Or
I
you're
mean,
worrying about
if
scurrying
yeah,
around to get a place to live. You're not paying attention to whether you might have HIV.
well, if you think about it in general, right? There's sort of Maslow's hierarchy of needs, right? Sort of the
Uh-huh.
basic necessity, the need to have a place, the education, the access to opportunities, right? So, and there's been several sort of studies, both internationally and locally, that kind of demonstrated that if you think of providing individuals with opportunities, for instance, right, to sort of stay out of trouble. If we were to kind of borrow models from the criminology literature and other places where you provide individuals with opportunities, they're more likely to sort of focus and live a productive life. And I think it's no different for HIV. We shouldn't necessarily think.
Specifically, how are you dealing with that day to day? What do you do when you're not here on the radio?
So most of my work focuses again broadly around the term called social determinants, which is sort of access to education, employment, thinking about how things like social support, social networks within the community. And so really, as Greg mentioned earlier, it's sort of modeling these sort of variables, if you will, at the population level to see, and quantify what is the impact that some of these specific variables have around, let's say, some preventative measure like.
So have you watched how a preventive measure got played out in one community and then tallied up the numbers for whether that meant more people got the help they needed and lived more productive lives?
Yeah, so that would actually be the ideal situation that most sort of public health researchers
So where's the
live
place you
for.
did that?
So well, I can kind of give you one example. I worked with some colleagues at Harvard to look at using a data set with African Americans, a representative sample of African Americans across United States, and we've looked at something called access to PrEP, right? So places that
I was going to ask you about
prescribe.
PrEP. Now, PrEP is an acronym. It's a capital P, lowercase r, capital E, capital P. What does that stand for?
So it's pre-exposure prophylaxis. So it's currently in the form of a pill that you take once a day that can significantly lower your risk of acquiring HIV. So in some populations in randomized trials, it's showing up to 96% effective.
So if you go to a
at averting.
population that's at risk of getting HIV, you ask people to start taking preventative pills. So where do people do that?
So currently PrEP is available through the healthcare providers. So it needs to be prescribed, right? So so at some point you have to get engaged with the healthcare system. You have to speak to a physician, and at some
Which
point,
brings up a paradox that the people who need it most are going to be least likely to ask for it. Is that a fair way to put it?
well, I wouldn't say least likely to ask for it, but if you think
Or
of
to know about the need for it, maybe.
well, one, knowing about the need, but also the opportunity. So I want to sort of give you an example about how we can use modeling in this instance. So this the same sort of study I'm telling you about is where we took sort of the geographic access to places that prescribe PrEP, and we were able to map those centers on, and we were able to sort of create a measure called the density of places that prescribe PrEP, so access. And we've shown through statistical models that areas where there's higher density of places that prescribe PrEP, the individuals that live in there in those areas, specifically within our study, had higher likelihoods of being willing to use PrEP, right? And so
okay.
the ideal situation next would be to say, well, how can we actually model if we were to scale up the number of services? Then what would be the proportion of increase, for instance, we would see within willingness, but then within actual use of PrEP, right? So I think again, using our research, to provide certain scenarios that we could then inform policy, that we say, okay, what if we introduce 10 new centers? What would be the approximate number of lives saved, or the approximate number of incidents?
What's the biggest takeaway you found out about PrEP?
Well, we had the beginning of this work, and I think that's where, as highlighted, we had a really great time and an opportunity to kind of look at how these things would eventually have long-term impact. So I think we are just at the beginning of the work, being able to start to model these things in terms of figuring out the number of lives saved once we're able to scale scale the population level.
Yeah, we're talking about World AIDS Days coming up this weekend, talking about HIV and AIDS with two people on the front lines of the research and activism on that issue from the Yale School of Public Health, Greg Gonzalez and Yusuf Ransom. It's really appreciate having you guys here. In the time we have left, I want to ask you, what are the major challenges going forth? I have a feeling it keeps coming back to access and education. In the next year, what are you hoping is going to happen in the fight to combat HIV and AIDS and help people live long, productive lives? What's the top of the agenda?
Well, first of all, for all your listeners, they should get tested on World AIDS Day or sometime in December. So they should know their status, because they can't get access to care and treatment unless they know they're HIV positive.
Now, if you don't use intravenous drugs and you don't have other sexual partners, it's still important to get tested?
particularly if you're a gay man or men who have sex with men, or you share needles, yes. But you should talk to your doctor about your sexual history, and talk together with your healthcare provider about whether you should be getting an HIV test. In many cases, it will make sense. In some cases, it won't. But young people are sexually active. Just because you know what you're doing doesn't mean you know what your partner's partner does.
Right.
As Yusuf said, social networks and sexual networks play a strong role in predisposition to infection.
And that's why I was listening. I thought he brought up that criminal justice research parallel, because there's been Yale social network research has been working with the U.S. Attorney's Office and the police in looking after violent crime and looking at social networks, who's most at risk of getting involved in crime or becoming a victim of crime. What Greg, you talked about neighbors. What even within neighbors, what census tracts you have to look at where it's most likely. They've had success in steering law enforcement to concentrate on outreach where the problem exists. I feel like I'm hearing a similar idea about how to use data in social networks.
Yeah, I mean, around the gun violence stuff, there's been a group called the Interrupters, who look at social networks and think about where gun violence is likely to happen. We're talking about public health interrupters. PrEP.
And as does exist, do you hope that's what PrEP is?
PrEP can do it, condoms can do it, clean needles can do it, but knowing your status can also do it.
So I'm sorry, you said condoms,
clean needles, PrEP, what else?
And getting tested.
Getting tested.
Sort of combination therapy is sort of the acronym or the
And is there a group that calls themselves public interrupters, or are you just saying
we
that?
Just made this up.
All right. Well, it made up right here. So you talk about World AIDS Day, Greg. One thing is that you think people should get tested. Other ways you're going to mark it? I know there's an event here in New Haven. How are we going to mark World AIDS Day? What are you guys doing Saturday?
I think sort of just again looking for opportunities to basically share what we know. Kind of think about new research opportunities that we can do to sort of again interrupt the epidemic, whether it's here in New Haven, nationally or globally. So I think that's sort of always on our agenda, and I think World AIDS Day is just sort of a fitting place of remembrance and really just coming together as colleagues, as friends, as family, and just sort of being able to share what we know with the general public.
Finally, the AIDS Project New Haven has just renamed itself and broadened its mission to deal not just with HIV and AIDS. Do you know why that was and what that's all about? Okay.
I don't.
Okay, no problem at all. But I appreciate Greg Gonzalez and Yusuf Ransom. Thanks so much for coming on Dateline New Haven today, spreading the word about stopping the spread of HIV and AIDS. Keep up the great work. And any last minute information you'd like to give people where they should go for information to find out more, get involved?
Instead of the websites on Yale School of Public Health,
Yale School of Public Health.
We'll have some information on there posted. That individuals can kind of go to get other resources.
So go to Yale School, Google Yale School of Public Health.
So we'll have a page up there for the World AIDS Day that then you can have some references onto.
All right.
There to go.
Well, thanks again, guys, for coming in, making time.
You're welcome.
Keep up the great work.
Thank you for having me.
Thanks to Yale New Haven Hospital for providing support for today's program. We're going to take it out with the Afro-Semitic Experience, performing I Wish I Knew How It Would Feel to Be Free from the group CD, A Plea for Peace. Now, we know what it's like to be free. We just got to remember to book our flight. Fly free with us all day and all night long here at WNHH, New Haven's home for community radio.